I am Travis Good. This is Dr. Blatt. This is going to be a fireside chat, sans fire. We are going to open it up for questions from the audience, and if you guys want to send them via Twitter, that would be fantastic as well. I'll be moderating. Mark, I had the pleasure of talking to him for a few minutes earlier today. Actually, it turned into much more than a few minutes. Mark's really got some pretty phenomenal use cases and real-life stories of collaborative workflows, which is what we're going to be discussing today. So I don't want to talk too much. I'd like Mark to do most of it, and I'll try to direct some of the topics and also feed in some of the questions from you guys as you have them. So with that, I'll hand it off to Mark and give a brief introduction of himself, and I think he's got kind of an interesting story of how he left his medical practice and ended up at Intel.
By training, I'm a family doctor. I practiced, maybe almost about 20 years, most of it in a small town in Enfield, Connecticut. Started out solo, grew the practice. Somewhere in the mid-90s, probably a 4th of July weekend, like just passed, I was covering for 12 primary care docs. Now, covering for 12 primary care docs is a good thing and a bad thing. It means you don't take call very often, but if any of you are primary care docs and you realize you're going to be on a 3-day holiday weekend covering for 12 it can be a bad weekend. Rounded in the hospital really quickly Saturday morning, and if your mom's out there, you often wait till Saturday morning to call me. You're good enough. When the kids get sick at 5 o'clock on Friday when the doctor's office closes, you wait a few hours. So Saturday morning, probably between about 7 and 1-ish, I probably got 200-300 phone calls, more than I'd ever gotten before on a weekend. Now, it's a holiday weekend. You can't send them all to the hospital or the walk-in center. You got to be a little bit of a wall, not sending everyone there. Your colleagues are going to hate you. So I asked a lot of quick questions, and I found myself triaging and treating a large majority of the people that called in. Probably by the time I was done, I realized I had probably taking care of 75% of the people, and maybe 25% needed follow-on tests or something I couldn't do on the phone real quickly. I started to wonder what the heck I'm doing in the office on Monday. I began to feel like a little bit of a shaman. Basically, I had, quote, taken care of more people, 150-ish, than I take care of in a week. It had been very convenient for the patient. Maybe the downside for me is it was free. I didn't get paid for it. And it might have been illegal. So aside from being free and illegal, it seemed like a good idea. I mean, this to me struck me as the future of healthcare. Monday morning, all the calls get intercepted by various secretaries, become billable events. You take a half a day off from work, come see me, pay a couple $100, and we got the same outcome. I didn't get it. So I started bugging my colleagues about telecare, remote care. And again, aside from the fact there was no business model and it was illegal, it was a good idea. So I left practice, went and got an MBA, and showed up at Intel. And maybe 15, 20 years later, I think we're at the cusp of that practice model becoming the reality. And that's why I ended up here. How can I deliver care for 10 cents on the dollar to the majority of my patients?
So what's funny about that is my wife is an MD, and we have a lot of friends who are MDs, and we get all of our care for free and illegally because we never end up going to the doctor. People just text pictures back and forth, phone calls, and of course we don't pay our friends for the treatment and the prescriptions. But what's ironic about that is it sort of proves that that model works, at least with informed and educated patients. So I wanted to sort of transition a little bit to some of your experiences at Intel and some of the things that you've seen at Intel. I know we talked about this a little bit before, and we talked about what you'd seen, some of the hurdles, not just from a technology perspective, but also from a policy perspective and an incentive perspective in terms of getting physicians on board and working or breaking their typical workflow like they have now, which is volume-based, so patient after patient after patient. How do you get them to actually engage real-time or near real-time? And you had some really great examples that you were talking about in Chicago with Kaiser and some others, whichever ones you like to share. I think they really highlight how you can effectively do real-time clinical collaboration and deliver very good care, and at the same time encourage and incent quality care.
Everyone, I think, knows, and I wasn't joking when I was talking about the business model. The business model that we have is incredibly broken. And the only reason I'm sanguine on the fact that change is about to come is because the model is so broken, that we are literally bankrupt as a country trying to deliver care. Arguably, it was healthcare that bankrupted GM. It's healthcare that's bankrupting most of the states. The feds can't afford it. My company, Intel, can barely afford to give us healthcare. So literally, the problem with healthcare is it's in a bubble. The product that we all produce, that we all deliver to customers, patients, is unaffordable. What happens when a product's unaffordable? If I had told you 6, 7 years ago your house is going to be worth half of what you thought it was worth, you would have told me I was crazy. You had nothing but 70 years of history to show it goes up. When bubbles end, they end non-gracefully. And I don't know when this bubble is going to burst or how it's going to end, but you can already start to see the air coming out of it. What the feds are willing to pay for an office visit is probably below the fixed cost of most people for an office visit. So the business model is already busted and unsustainable. Healthcare is consuming 18% of GDP and crying and dying that they can't live on it. Could you give us a raise? I mean, it's almost nonsensical at that macro level. I think the challenge with the Affordable Act that we're seeing, and again, I'm the worldwide director with 3 billion people coming online in Central Asia, Latin America, and Africa, is how do I deliver care, not to 30 people a day, but how do I touch 300 people a day? So I can't go down from an 8-minute visit to an 8-second visit. I have to completely change the way I deliver care. And that kind of goes back to Saturday morning. And what you see is some of the larger, more innovative organizations, both here and overseas, doing just that. You know, from a policy perspective, for a technology as simple as e-prescribing raises all sorts of issues in the United States. We had to incent, bribe, doctors to go forward and do e-prescribing. In 2004, Denmark, the Danish Medical Society decided to be a member of the Danish Medical Society. By the end of 2006, you had to do e-prescribing. It's Denmark, 5 million people, about the size of Rhode Island. I mean, but it's a sovereign. The rest of the Nordics followed suit. I once asked the Danish president of their medical association if he could come talk to the AMA. He told me it'd do no good. The AMA basically would look at this from an economic perspective and how it would affect its members. And that's part of the fundamental issue. The work that we're about to talk about doing as doctors, if we go to this virtual care model, the fundamental work changes. I became a family doc because I fell in love with Marcus Welby. I wanted to be Marcus Welby. Home visits, hug people, get them to know me. You know, I did all of that. That's exactly what I did. Every weekend I was out there, medical director. The model's unscalable and nonsensical. It's produced the most unaffordable, unaccessible healthcare system in the world. It's time to put Marcus Welby to bed. He's gone. Go on to a new model. The model of virtual care is being embraced in the United States by organizations like Kaiser, the VA. The VA is probably the largest consumer, but we go back to that rational economic model. VA doctor isn't trying to figure out how many more patients I can jam into my schedule. He's got a list of things he has to do for a given number of patients, and his resources are diminishing. So not only do I want you to figure out how you can go from 30 to 300 patients, but I'd like you to figure out how you can do that but cut the cost of every encounter in half. I'll call it Moore's Law for healthcare. Double the volume and cut the cost in half. I want to ask you to do it every 18 months. Do it once in a decade. And that would be a service to citizens in the world. So Kaiser actually has a series of pilots going on virtual care. They've been very successful in their Hawaii division in moving care into the virtual arena. By some estimates, probably half of the encounters that Kaiser does in the Hawaii division are virtual. Meaning not face-to-face. There's some other, like you with your friends. Now, Hawaii suffers from big distances and travel. Doctors aren't where the patients are. But that also describes a lot of rural areas in America. It certainly describes India. It certainly describes much of Latin America. So again, I'm the worldwide director. So I start to look at these models and I say, okay, even if I can't get them into urban US immediately, eventually when I can offer a citizen a visit for 10 cents on the dollar, which again now is less than their copay, and let them decide if they need to get in a car, park somewhere, you know, take three sick kids, let them get sick in the waiting room for the one kid to be seen. If that's the model that they want to keep doing, fine. But then again, to come back to doctors, we have two issues. We got to get citizens to want to move in this direction, and there's not a groundswell of demand for this. That's kind of the problem with innovation. If you ask customers what they want, they often look at sustaining improvements. I guess the favorite quote came from Henry Ford: if I had asked my customers what they want, we would have said a faster horse. We're not going to make this work by building a faster horse, by applying IT to the same value proposition. How do I go to 300 touches a day and cut the cost in half for every touch? How do I get down to that 10 cents on the dollar? And that's what Kaiser is kind of looking at. That's what the VA is looking at. That's certainly what rural China is already doing and implementing in many ways. Most of the doctors, quote, in rural China that take care of 800 million citizens have what we would probably consider a high school education. And they're using IT to support it and IT to deliver care for routine chronic disease. Not the corner case, the cancer, the complex, but 80% of what the costs are chronic disease. And they're doing more and more self-empowerment and more patient-directed care. Might want to ask pharma, at what point could we actually let patients order their own medicines? At what point should citizens order their own lab tests? Why do they need me for every little thing that they do? They need me for the complex things, they need me for judgment, but increasingly that judgment is transitioning to online decision support tools, which are only going to get better and better and more powerful, and they're in your pocket anytime you need them, wherever you are.
Yeah, I think those are great points. And I think that as we talked about earlier, the systems that are driving it, the examples you gave, I mean, China obviously is a fairly centralized, at least in rural China, fairly centralized system. And then the examples in the U.S. of Kaiser and the VA are also, systems where, again, it's easier to incent the provider. That's and that is a political, that's a payment battle, that's a specific type of battle. But looking at the technology side of things, from a real-time collaborative care perspective, there's some easier models. There's some models where it's just sort of asynchronous text-based, or it's, as you gave an example to me earlier, of a Canadian hospital using FaceTime to do synchronous video virtual consultations. But to me, it seems like you obviously have to overcome the political battle. You have to have physicians, or the payment battle. You have to have physicians who are incented and want to do it. You have to have connectivity, right, which we talked about how they overcome that in some places. And then, there's certain services and access to data that we talked about as well. Things like device data, streaming echocardiographs or radiograph data, things like that. To you, I'm curious, if you were to have sort of your ideal technology solution, assuming the rest of the things are taken care of, from a technology standpoint, what does that look like to you in terms of what things a physician has access to, be it video or monitoring data or things like that? What does that actually look like?
Well, the first thing, I'd change physician to clinician, because I think, as we all might agree, mid-levels and other providers are going to become increasingly more important. And I think the job of the physician at the top of the license is going to be to direct care and maybe not see people face to face. Again, my Marcus Welby existence is diminishing. I think about that a lot in terms of the platform. What will the platform look like? And we often talk about the device level at the platform, and while the device is very important, I'll throw out a thought and then come back to the device. I think the compute models and actually how we deliver information to these devices is going forward as technologists, as a technology company, probably even more important. So the cloud, big data, edge data analytics, how I deliver information to that device, whether it's a tablet, a phone, a laptop, a Google Glass, your wearable watch, whatever comes next. Those devices are going to continue to innovate and proliferate. Where the compute power rests and how I help the end user make decisions, I think, is going to become the more powerful idea. If I can impact a diabetic by sending them a preferred menu of what they should eat that day, that's very helpful. If I know their geolocation and what restaurant they just walked into, and I knew the menu of the restaurant, that's very helpful. If I could then, after they ordered the food, take a picture of it and use big data to actually tell me the calorie count and break down carbs, protein, and fat to actually confirm, that's even more powerful. So again, where the technology might rest for the first one, might be on a server in the sky for kilobytes of data. But the edge analytics to analyzing the image might want to rest in the camera itself. You might not want to send that back and forth on the network. You could, Intel thanks you, Cisco thanks you, and all the networking people. Thank you. But again, you might be building data centers and networks that are unnecessary at that point. Devices are becoming more and more intelligent at the edge of the network in delivering information that is relevant, not just data. I mean, it's one thing to deliver a potassium, and if you're a clinician and you spent a career figuring out what that means, then I can get your electrolytes and a set of values and make an intelligent decision. But what if I want to deliver information to an end user so that they can help better manage their own diabetes or avert a complication? You know, lab values are particularly interesting. Again, talking to patients tomorrow will be interesting. There are 18 states where you're allowed to get your lab values direct and 32 states where you have to go through a physician. What other product do you pay for that you're not allowed to see? You're contractually obligated to pay for it, but you can't touch it or feel it unless someone... And studies from docs saying, oh my God, if patients saw their data, you know, unfiltered, they'd jump off a building, they'd kill themselves, they wouldn't know what it means, you know, or it would clog us up with so many useless phone calls. None of that turns out to be true in the states that actually do allow it and the studies that do study it. We heard one other comment briefly about primary and secondary adherence, and again with patient empowerment and giving patient information. There's been some recent studies about opening the medical chart and allowing the patients to read raw doctor's notes. Terrifies doctors. But again, I mean, it's your data. They're making comments about you. One of the, a recent study from both, I think it was Boston Medical Center, Harborview, and Geisinger, looked at several thousand patients over about 9 months. First off, about 20% of the docs were skeptical about joining it, and nobody dropped at the end of the study. They found it too useful. About 8% of patients were worried about privacy and confused, but about 85% of patients felt more empowered, part of their health care, and about 70% improved patient medication compliance. They didn't even speculate why, but medication, maybe because, I don't know, Dr. Blatt wrote non-compliant, obese, hypertensive, likely to die early, let's get a bypass. I mean, you read that note enough times, maybe you start to, so maybe our notes have value. I mean, because we're actually telling patients what we think instead of filtering it. So, but again, opening up and involving and collaborating with patients, that's that consumerization. So what's the right device for the patient? Probably going to be a smartphone at the end of the day. That's going to be the right device for delivering information to the citizen. But for clinicians, docs may carry around 7-inch devices, nurses slightly bigger. You know, again, I think wearable computing and perceptual computing, if we were up here 3 years from now, we're going to have a different conversation. But the compute power, does it rest at the server as part of the network or in the device? That becomes an interesting balance going forward from an IT company's point of view. And I think the answer is all three.
Okay, so I tried to move away a little bit from the political stuff, and maybe we're coming back to it now. And I think it's in part because maybe technology is not the only issue, or not maybe, but technology is not the only issue. And we do have pretty good technology, and I'm sure Mark can tell you even better technology in the pipeline. But you mentioned state-by-state rules regarding access to lab values, and we talked a little bit about state medical boards. So how do we start breaking down some of these barriers? What are the steps for us to move from where we are in terms of state by state and providing access in this state versus that state, or requiring a physical exam to treat a patient in this state versus that state, or a previous visit in person to do it? There's all these various rules which are they're really difficult to wade through if you've ever actually looked. How do we start to break those down? What's the groundswell? Is it from patients? Is it from consumers? Is it from larger health systems? Is it concierge? What's gonna break some of those down?
I think the short answer is cost. Mm-hmm. Again, we're in a bubble. Healthcare has become unaffordable. None of us as individuals can actually afford healthcare in this country. You might have to go to Thailand to afford healthcare. So how do you get affordable healthcare? What if it's offered to you? I mean, what if somebody actually offers you a concierge service on your tablet? And in order to escape the Byzantine regulations of the United States, we'll make it up. It comes out of some third world. It's on the Isle of Man. You know, come get me. Pharma had a problem with reimportation. Several states actually adopted it for their state employees, kind of interesting, in flaunting the federal government. But you can't stop the change, again, because of the cost incentive. If I can deliver a visit for you for literally pennies on the dollar that's safe and effective, rather than you getting up and going to see your doc, if I can then even actually start to coordinate care for you remotely, because now most of your physicians are going to be remote physicians that I'm going to be dealing with. Again, it's not all the care. I'm not about to do, the Da Vinci robot's not showing up at your house and saying, lie down. Not yet. 10 years out. But again, primary care, hypertension, diabetes, COPD, CHF, so much of what ails us can be treated in this collaborative fashion. So I think it's a groundswell based on cost. I'll give you a very practical example. What if you know as a citizen, your kid had an asthma attack, you call the ambulance, going to the emergency room now has a $500 copay. By the way, if you're a Medicare patient, that's what it has, unless you buy a copay plan to cover non-covered expenses. And then you have a 20% co-insurance, not co-insurance. So a $100,000 hospital bill is now going to be $20K for you. So now all of a sudden the ambulance driver says, if I open up a video conferencing technology, I got an environment here where I can actually talk to a specialist, maybe even your family doctor if he or she's online, and the community health worker for this area. Maybe we can treat your kid's asthma attack here and in place and avoid a transport. What if EMS said that to you? Well, now EMS is in competition with your emergency room. Well, in places it's been tried, it's dropped ER visits by 30, 40%. Now, by some arguments, 80% of all ER visits are unnecessary. So I'm only attacking half of them with this initial proposition. But in technologies where we've looked at patient-centered medical home and where people have tried to actually collaborate and coordinate and form an ACO payment model that resembles Kaiser or the VA, because that's how they're going to get paid as a global capitation. Study after study shows that when you get to level 3 patient-centered home, you are actually decreasing admissions, readmissions, office visits, and ED visits. You're basically going to put the hospitals out of business. Probably half of them go out of business in the next 10 years. That's the biggest change. It's similar to what happened with DRGs. DRGs were our last big change, so it was 1982. 1980, we had about 9,000 hospitals in the US. By 90, we had about 6,000. About a third went out of business. Germany went to DRGs in 2002. They lost about 25% of their hospitals by 2006. So again, I think this is another game change here. We're going to increasingly move med-surg. We moved surgery out of the hospital. Now even med-surg, all CHF and all the things that we brought people in for, pneumonia, kidney infections, cellulitis, increasingly going to be treated in home-based systems that collaborate care. And now I mean collaborate with EMS, home care, the pharmacist, the visiting nurse, the family doctor, the hospitalist. That's the coordination I mean. Doing a great job in your office, seeing people one at a time, waiting for sick people to show up, that was Marcus Welby. That's done with. I don't care what good job you do in your office. If then you don't collaborate care when the person leaves, you're a cost center for me, and I don't want you in my ACO.
And I just want to make a comment that I love the virtual concierge concept, and I'm excited that I've actually spoken with a bunch of docs recently that are still independent that are looking to try that out in their practices. I think it's fantastic. If
you can get the cost model down below the cost of the insurance company, that's what we were talking about. And again, thinking of as a clinician, it's not what I make, it's what I take home. If 70% goes to support my overhead, maybe I can charge 70% less. So if I could charge $15 for 10 minutes of my time, I don't need an insurance company anymore. Primary care, and a lot of this we get the regulators, the insurance company, and the government out of the business because we made care affordable again. Not everything. You're still going to need catastrophic care, but maybe that's what insurance really should be. It should be insurance for catastrophic care, not a menu of covered items.
And I just wanted to say we have about 6 minutes left, so if anybody, I think there is a microphone floating around somewhere, so if anybody has questions, feel free. I think we have one up here in the front.
I'm curious what impact you see on descaling in the medical field. How do you see that continuing to evolve over the next, let's call it 5 to 10 years? And what are the areas you think it's going to be most impactful in?
Most impactful probably in outpatient primary care. That's probably the most obvious. But I also think in imaging it's going to be increasingly impactful as artificial intelligence moves to find me an image that looks like this image for derm, path, and even radiology diagnosis. I think you'll start to see computer-assisted diagnosis move very rapidly into those fields. They were the first to digitize all the data there. But in primary care, outpatient, again, I'll go back to an example in China. Most of the people who provide care for 800 million rural citizens have what we wouldn't even consider a mid-level degree. They were trained more along what we would think of as training a medic in 8 weeks, to go out and do care in the field. But they're supported with clinical decision support. All of rural China has broadband connections. About 10 years ago, China Central Committee ordered China Mobile to put 10 RMB a month, about $1 a month, broadband into every rural Chinese office that wanted it, about 1 million free lines. Can you imagine the U.S. government turning to AT&T or Verizon and say highly subsidized broadband for all clinical facilities? The value in being a communist government. So the first thing they built was the connectivity. Then they actually incented the doctors to give the right medicines by saying, if you give the wrong medicine, we'll pay you, but it'll take about 3 months. If you give the right medicine for the right condition, and there's no reason you should be trained, you'll enter it in real time, it'll go to the provincial capital, you'll get an ACT or a no ACT back, and it'll support your decision, but then we'll pay you in 3 days. It was money that moved them in the right direction to adopt the right practices, and they were able to develop a rural healthcare system very quickly that provides primary care. Again, I don't think we copy that in the U.S. I'm just pointing out going to de-skilled care, if you will, lower skilled care. Why can't an algorithm manage your COPD? Why can't an algorithm, or even for that matter, an avatar, manage your hypertension? It's not when your teeth are green, you're blacking out, and your toes are yellow. I need a doc for that, okay? But your blood sugar's a little high, it's an algorithm.
All right. I actually have a Twitter question here. How do you see, this is from Simon Sikorsky, apologize if I messed up that name. How do you see e-patients empowering technology innovation, specifically at Intel?
I go back again to that self-empowerment model. Physicians are going to become, I don't want to say less important. That's not the right word. The job they do are going to be different. Seeing people one at a time face-to-face is not the job. E-patients and the ability to communicate either through chat, IM, video conference, whatever's the most convenient way, 24/7 for the patient, that's the reality going forward. And whether it happens in the United States or you use overseas resources with business models that come into the U.S., I think that's the grassroots reality. We can't afford care in many places, but we can't afford a cell phone. The telecommunications costs are becoming incredibly inexpensive. E-patients are a reality. Patients that manage their own conditions using valid information and valid protocols and get good results, if not better results, than coming into my office. It's funny, there was a book I read as a resident called The House of God. And it was a joking phrase in there that when the residents were trying to walk in the room to see the patient, the chief resident pulled them out, and he said, patients are best left unseen or untouched. You hurt them when you go in the room. I thought that was kind of a joke at that time, but maybe there's some reality to it 30 years later. There might be ways actually to treat patients much more safely, avoid nosocomial infections, the cost and inconvenience of... How many of us delay in getting treatment because it's inconvenient? So we wait till we're sick enough to go to the doctor. Versus if you could do it with a push of a button, maybe you would treat whatever it is we're talking about days sooner.
Do we have...
Lots of questions.
Yes, thanks. If you give patients access to labs, and particularly to physicians' notes,
yes,
won't you increase liability, litigation, and won't the system, the providers, be resistant to it? I mean, everything that you do now is documented to an extent that someone can go in and drill down on it and say, you missed this one little thing.
The American Lab Association did a study on what percentage of critically abnormal values are never reported back to patients. Take a guess at what they are. 7%. Your mammography was filed away, it was abnormal. Your pre-op chest x-ray, no one looked at it. We forgot that nodule, but your knee is doing great. Okay? So now part of the barrier for malpractice is I got to be better than that 7%. It's not a really high barrier. We basically suck at reporting lab values. So if I opened them up to the patients, I'd obviate that whole cause of malpractice because I gave it to the patient directly. So I'm removing liability from the doctor in that sense, in that fashion. Now, opening up the medical record, again, in study after study that did this, it didn't show that it increased litigation. It might make your notes a little bit more thoughtful. It might make your notes a little bit more helpful. And maybe there's some exceptions to some notes that you don't want to open up because they would be harmful to the patient. But unless the note is actually going to be harmful to the patient, then I think it's the patient's data and they have the right to see it. And you have the obligation to make it understandable.
I actually think we're just about out of time, according to the zeros. So, one more?
One more would be awesome.
Sure.
Hi, Dr. Blatt. I'm loving your talk. My name
you.
is Robert Bond with the New York eHealth Collaborative. And one thing we're doing in New York is driving innovation through providing innovators with access to electronic medical records through the State Health Information Network of New York. And what I'm curious about is how to apply what you're saying to driving innovation. I want to know what you thought about what does healthcare look like in the U.S. in 2020 and 2025. So what kinds of things, I'm just wondering what kind of levers should I be pulling? What kind of innovation should I be driving forward?
Well, first I'll say hi to Dave Whitlinger, former Intel colleague. Again, I think care is less face-to-face. So the eHealth Collaborative and the ability to collaborate and do things that now require you to go to a physical facility. Intel refers to it as the mainframe. Distributed computing was Intel's biggest innovation, so we all have computing power in our pockets that exceed the mainframe. I don't have to go there with a bunch of disks and punch cards. Yet I still have to go to the doctor's office or go to the hospital to get collaborative care. I mean, the hospital was a great invention, 1840 Vienna. I mean, I think we could have moved beyond 1840s Vienna, and it doesn't have to be the only way we practice and organize care. So e-health means groups of virtual physicians forming. It might mean instead of being part of the eHealth New York Collaborative, it's the New England Collaborative or the East Coast Collaborative or whatever bandwidth will support, because I do think licensure regulations in some ways violate the Interstate Commerce Clause. I think everything we've been talking here is about healthcare being non-local. And if healthcare is non-local, why are states regulating it? So the Commerce Clause would apply in the Constitution, and it becomes a federally regulated facility. So I think if I looked at healthcare 20 years from now, it's less face-to-face, it's more virtual, it's more empowered, it's more algorithmic, it's more immediate, it's more real-time, there's less waiting. The costs have diminished dramatically for at least primary care, for at least even probably secondary care. Quaternary care, tertiary care, maybe we're still up there.
Fantastic. Well, that's a pretty positive note to end it on. So,
Thanks.
thank you, everybody.